I'm coming to this, I don't pretend to be an expert at all in working with people who don't have homes or on the streets. And again, a lot of this is about serendipity and having been dragged into it by my colleagues who are sitting over there on the homeless team. So I have a little bit of experience, but I want to try and bring a different type of viewpoint for you to consider. Firstly, going to the general press, you can see even as far back as 2012, there are certainly some problems in the clientele with which you work. And you can see that, from my perspective, that a significant minority of patients or people are going to potentially have quite severe physical and intellectual damage as a consequence of alcohol and malnutrition. Indeed, if you go to the hard research behind this, going back 10, 15 years or whatever, you can see the Glasgow study showed an awful lot of heavy drinking and an awful lot of intellectual damage. So the first point that I want to make is that there's probably an awful lot of damage out there as a consequence of alcohol problems and nutritional deficits. So what is this thing, Korsakoffs? Can I see, has everybody heard of Korsakoffs? Okay, let's unpack that just a little. Probably the best word you want to use is alcohol-related brain damage, because this allows you to be much more inclusive in the people that we're going to try and help. Korsakoffs in its pure form is actually a very rare condition, but actually if you include all the other aspects of the way alcohol and vitamin deficiencies affect the brain, you actually have a very much larger problem, which are very difficult sometimes to diagnose. Alcohol-related brain damage is actually quite a significant problem in this group of people. And how does it manifest? Fundamentally, it manifests with two fundamental problems. You've got memory problems. These are people attending an alcohol treatment service. You've got memory problems in approximately 30%, and you've got frontal lobe problems. Now, frontal lobe problems is where you do all your thinking. It's about weighing up information, and we'll come to that in a moment. So there's a significant group of people who are attending alcohol treatment services who have a significant amount of intellectual damage as a consequence of the alcohol. And to get this intellectual damage, you need to be drinking, as a female, 30 units a week for about 5 years, or 50 units if you're a male for 5 years. Now, you will all know clients are drinking far more than that. So there's a very strong probability you're working with quite a lot of intellectual damage. Let's take a look at some of the short-term problems, short-term memory problems, and long-term. You can lose 25 years of your life, memories, with this damage. 25 years. So when you're 50, you think you're 25 years old. Think about that. That's scary. Not only that, but your brain starts filling up those gaps with false memories, and you can't tell what's false and what's true. What are the implications of this? Well, here is an interview with a lady who's been through our treatment program, which is basically behavioral training, and has come out the other end. And I just want to run through this interview. She's given me permission to give it. So, what I'd like to ask you a little bit about is your memories over the last 3 or 4 years. Answer. Because I forgot what was going on, I turned to John, her husband, thinking he knows the answer, and he understands. He understood what I was going through and would suggest something, and that's how I managed. Do you remember the issue about alcohol all those years ago? And this is the important thing. I remember drinking, but even though he told me I was drinking too much, I couldn't remember drinking the previous time, and I was sure I was not. In effect, ladies and gentlemen, every drink this lady has is her first drink of the day. And yet, when she goes to alcohol treatment services, she's called an alcohol denier. I would suggest that it's because of her memory problem. What are the practical implications of memory on an individual, whether they're homeless or not? Obviously, they can't remember when they last had a drink. They can't remember or manage information that you gave them, even the day before. They might not even remember having an interview. They won't remember the last hospital admission. They won't remember the consultant saying your liver is going to be damaged if you continue drinking. You're going to die of vomiting blood, or you're going to dement. You're going to become incontinent. They won't think of that. They won't remember it. They've only got vague memories of their life. So when we're talking to them about getting personal histories, it fades away into sadness and emotionality. Let's have a look at the frontal lobe problems. Difficulty in concentration. People can't change from one stream of thought to another. Reasoning difficulties. They can't weigh up information. They can't bring variables together for you to understand and calculate and understand risk. They can't make choices about decisions that you think are normal. They can't plan. They can't anticipate future. They get breakdown of interpersonal relationships. They lose their motivation and their empathy. That's what frontal lobe damage does to people. And that's found in 50% of people attending alcohol treatment services. What are the implications to that? You take them to an alcohol service and they give you plenty of information. They can't handle, potentially, they can't handle it. It goes in one ear and out the other. They can't see it affects them. They go back into their environment where they're in a groove of work, of living with people who are potentially homeless. They're all drinking the same. And within a day or two, they've forgotten the interview. They have normalized back into the circumstance. They can't understand risk, how it applies to them. Can't deal with, have a drink. Impulse control is gone. Can't handle choices. This is what alcohol-related brain damage does to people. Here's an example of a reasoning problem. This is a verbatim again. Why can't I go to the pub? Because when you drink, you have a fit and end up in hospital. It's the fits that get me into hospital. Yes, and it's the drinking that sets the fits off. But I go into hospital because I suffer from the fits, and that was caused by my head injury. That's true, but when you drink, it makes your fits happen as well. But the doctors told me that I have to have tablets to stop my fits. Yes, that's right, but alcohol makes your fits worse. But my fits are there because I had a head injury, the doctors told me. Yes, that's right, but the head injury makes you more likely to have fits when you drink. My tablets stop the fit, but not when you drink. But the head injury causes my fits. We've got three variables here: head injury, drink, and fits. And the guy can't manage this. He can only put down two and connect them. And you can go round and round and round. And because you've got memory problems, you have this conversation the next day, and the next, and the next. Let's look at the principles of how we can, or the principles of how alcohol affects your brain. If you're drinking 30 to 50 units a week for a few years, you're going to have some problems. The first is you're going to be drunk, you're going to go through withdrawal, and you may have acute encephalopathy, acute allergic reactions or toxic reactions of the brain. If you stop drinking this amount, it takes 3 months, ladies and gentlemen, for the alcohol to wear off its effects on your brain. 3 months of complete abstinence. If you are left with permanent or semi-permanent damage, your brain will take another year to 2 years to recover. It grows. You can actually see it on MRI scans growing when you're not poisoning it with alcohol. And at the end of this, a person may be left with some intellectual impairment. Permanent. That's the natural history of how alcohol affects you. Let's look at how we manage patients with alcohol-related brain damage? Well, fundamentally, we know that the brain is going to get better if you keep somebody abstinent. Therefore, under the Mental Capacity Act, if a person can't make a choice because they're so intellectually impaired about whether they access drink or not, they have the right, ladies and gentlemen, the right to be treated under the Mental Capacity Act. It's not punitive, it's their right. That's why the law is there. The therapeutic program basically maximizes the autonomy of an individual, trying to integrate them back into society, promoting their independence, and giving them the ability to make choice on whether they want to go back drinking or not. So they can sit down and say, no, thank you very much, Ken. I've done this, my brain's better, I can make a choice now. I know if I go back drinking, I'm going to end up incontinent in a nursing home with dementia. You say, fine, goodbye. That's choice. If you actually look at 72 cases that we've dealt with, we managed them for about just over 2 years. We have a 78% abstinence rate, 16 relapsed, and you'll see that the significant minority, over a third of them, are actually living in their own homes, independent of health and social care. We have a reduction of hospital bed days by 85%. These people were being admitted, the worst one, hit A&E 100 times in a year. So let's look at homeless cases. Well, fundamentally, I teased out 11 cases. 5 came from the acute hospital admissions. Gaynor referred 4 or 5, and we got a couple or 1 from acute psychiatry. You can see they're quite young, people are quite young. Now, the ACE-3 is the Addenbrooke's Cognitive Assessment Scale. It's downloadable off the internet. Anybody can use it. You just need to practice using it with somebody. It's completely IP-free. You don't need to pay for it. If you get a score under 85, then the chances are in Alzheimer's work, you've got a moderate to severe Alzheimer's disease. So you can see that these people had a significant intellectual impairment. Of these 11, we actually treated 5, not 4, and 4, not 3, under various aspects of the law because they were unable to make decisions. So we're dealing with the very severe end. But these patients, as we've seen, aren't just straight ARBDs. They're very much what we've been talking about all day. Multiple problems. Strokes, infarcts, cardiac problems, infections, psychosyndromes, active TB. So the whole idea is to be inclusive. I'll take you through one case. The names are all changed. 48-year-old woman, long-standing drinker, and you can see she'd been around the hospitals, she'd spent time in the pub, ended up kicked out, homeless, stayed with friends, went on the streets. When we picked her up in the hospital, she had a very poor short-term memory. She was conflating previous experiences with current experiences. She didn't know why she was in hospital, and she had a lot of alcohol-related problems as well. She was very physically poorly. After the physicians had sorted her out, we put her into a specialist residential home that we trained up in treating ARBD. And after a month there, she was beginning to improve. But you can see, really problems with memory. Unsure why she was there, couldn't remember the hospital. When you've got gaps in your memory, you start filling it up with these confabulations. And this developed into a psychosis, a paranoid psychosis, believing her daughter had locked her up here. And then she started hallucinating. So we had to treat that. She had one relapse in alcohol as we were progressively getting her out of the residential home, progressively getting her into the community, getting her a voluntary job. But she managed it and she came through it. We trained her up, we helped her improve her skills that she'd lost over the many years. We took her off the deprivation of liberty order. She now, ladies and gentlemen, has just finished a degree in criminology. She was a fabulous woman. And she's a good story. But here's a bad story. A failure. You can see this patient is very much like my predecessor was talking about. Been through the mill. You can see the person suffering. You can see the hurt in his eyes. When I first met him, Gaynor introduced me to him, as thin as a rake, vomiting with diarrhea. He couldn't go out and drink. He had a score of 54. He just could hardly walk. So he was in the YMCA for a little then, and Gaynor managed to keep him reasonably sober. And about a month or two later, his score had picked up. And that's when we took him on. He's getting physically better. Really big problems, though. You could see intellectually impaired. It's completely pointless having an interview with a gentleman like this, because he'll forget it the next day. You have to do an awful lot of hard work to get into the person's head. He was assessed by a deprivation of liberty person from local authority who thought that he had capacity. We moved him into a residential care home with support package and tried to get him onto the therapeutic engagement. We failed principally because we were unable to tie in the drug dependency unit. They couldn't manage him because of his intellectual impairment. We didn't support them enough in managing him. His sister, we didn't network into the treatment plan. She moved in, and we lost contact with him. He wasn't drinking when we lost contact with him, but I suspect he's dead. Let's have a quick look at an overview of 11 homeless cases. 5 on deprivation of liberty orders, 4 under the Mental Health Act. Looked after them for a couple of years. We trained up both a specialist nursing home and a residential home in treating those people, and we supervised them. 1 case remains in acute care. Look at this. All but 1, that's the purple line here, improved in intellectual performance over the treatment plan. So if anybody ever says to you that Korsakoff's untreatable, they don't know what they're talking about. These people can be helped, dramatically helped. Of the 8 cases, say 7 had ACE scores. Of the 11 cases completing, 3 relapsed into alcohol misuse, drug treatment. 1 remains homeless and went into chaotic drug use, that's one extreme. And 1 remains in acute psychiatric care. He's actually dying. 6 are now alcohol-free and in accommodation. 1's just finished NVQ training, and this is the lady that did the degree. Small sample, hard work. So let's summarize. We know a significant number of chronic alcohol misusers have cognitive deficits. We know a significant proportion of the homeless have a long history of malnutrition and alcohol misuse and are likely to suffer from ARBD. We know that ARBD interferes with memory and all the intellectual domains you can think of. As a consequence, I suggest and even if a person does know they want to change, they may not have the intellectual ability to manage that change. We also know that at least 50% of the small group I have changed their lives around. Let's speculate to finalize. I suggest to you that these people are unable to change their social habits because of the brain damage. I suggest that if we actually treat the brain damage, we can give people choices that they can manage. Ladies and gentlemen, in the absence of care of ARBD, I suggest to you that we are disenfranchising a significant minority of the homeless population. Can we break the cycle, ladies and gentlemen? Think ARBD, homelessness, and death. Thank you.